how do you make the diagnosis of obsessive compulsive disorder? Well, first you can have either obsessions or compulsions. Two, the person has the ability to recognize that the obsessions or the compulsions are excessive or unreasonable. And this addresses your question, Jill, which is, how do you discriminate people with OCD from people who are psychotic? It's this very criteria. When you push back on the OCD patient's beliefs that result in their doing or not doing whatever they do, they usually will give them up, recognize that they're excessive. I think in an earlier version, they actually used the word silly and/or repugnant. And I have an interesting example that goes way back to the beginning of my practice back in Boston. I had a man who came in, he had a lot of contamination fears, and one set of contamination fears had to do with any time his hands passed anywhere near his crotch, he would worry that sperm would get on his hands, and then if he went near a woman, he would accidentally impregnate her with the sperm that was on his hands. Now, dynamically, he had a history in his life of having 3 women whom he had impregnated, each with disastrous results. One gave birth to a disabled child, one horrible results. So there was a dynamic understanding of why this happened. So this was one of his contamination fears. The second thing that he had, which was even more unusual, was when he would see an attractive woman on the street, he would imagine somehow that a pubic hair would fly from her crotch to his mouth. And he would engage in about 5 minutes of getting the hair out of his mouth behavior like this. So let's call him Jerry. He tells me these 2 theories. And I looked at him and I went, Jerry, you really believe if you touch your pants, sperm can travel through the fabric onto your hands, and then you're going to get some girl pregnant? And he looked at me straight on and he goes, you know, Dr. Becker, I got to have some reason for doing all this crazy stuff I do. That's the kind of response you're going to get from the OCD patient. A contamination patient I had taught me something that I thought was very helpful. He said that after he got contaminated by something, you know, maybe he would sit in a chair where he worried that somebody before him had sat in that chair and had germs. And I would say to him, well, Bill, do you really think the germs can travel through, et cetera, et cetera? He says, no, it just makes me feel yucky. So there is this yucky factor. And interestingly, there's a whole body of research coming out now about the emotion of disgust. I don't know if you've read much about it. I just read a whole special issue of the International Journal of Cognitive Behavior Therapy, which is saying that this is an emotion that we have not paid enough attention to in anxiety disorders. We look at fear, but we don't look at disgust enough. And disgust might be playing a very big role in OCD, in phobia. So is the dog really dangerous to you, or is the dog just disgusting? It's going to change the way you might approach it. So a lot of times the OCD patients know that they are truly not at danger, but they're yucky. They got to get that away from them somehow. I think in very difficult discriminations of, let's say, paranoid disorder and OCD, you might fall back to some psych testing. And this is where I would make good use of psych testing if I really couldn't tell whether the patient truly believed it or it was part of the belief system that surrounded the OCD. And they can be pretty out there, as you just heard. So that's why I think we used to call it with psychotic features, and now we call it with poor insight.